Okay, so this is continuation of the last session. Okay, so the points we are going to discuss in this presentation is basically relating to acute coronary syndrome, chronic coronary syndrome, and heart failure. Okay, so the remember, if you have acute coronary syndrome, then you are talking about unstable angina, non-STEMI, and STEMI. If we put these three together versus stable angina on one side, stable angina is demand ischemia. So there is a block in the artery, but it's not enough to cause lack of perfusion during resting condition. You need a bit of exertion. So the supply, the demand has to increase a little bit to cause supply demand mismatch. But in acute coronary syndrome, unstable, non-STEMI, and STEMI, you have a supply problem. Okay, so the supply problem has reached a degree that leads to symptoms suddenly, acutely, and at rest. Okay, and basically, if you have any stable angina or non-STEMI or STEMI, all of which are thrombus formation on top of plaque rupture. That's the basic pathology. So it's a thrombus formation on top of a ruptured plaque. Okay. If it's unstable angina, so you don't have injury, meaning you might have ST segment changes or ST segment deviation, sort of depression, and or T wave inversion, but there is no elevated troponin, no marker of injury is elevated. Now in non-STEMI and STEMI, you have injury. Okay, so you have an elevated troponin. In non-STEMI, the injury is basically subendocardial. Okay, that's why you have elevated troponin, not as high as in non-STEMI, and the ST segment deviation takes the form of depression and or T wave inversion, but not ST segment elevation. Now in STEMI, you have transmural injury, and transmural injury expresses itself in form of ST segment elevation in ECG and a higher amount of elevated troponin. Okay. Now, since 2019 guidelines, they have discussed chronic coronary syndrome. They have talked about different phenotypes. So now, stable angina or stable dyspnea is considered one phenotype. New onset heart failure with suspected coronary artery disease, stabilized symptoms after acute coronary syndrome and recent revascularization, patient more than 1 year after initial diagnosis or revascularization, angina of vasospastic or microvascular origin, asymptomatic patient with coronary artery disease on screening. These are all different phenotypes of chronic coronary syndrome. Now, remind you that the pathology starts like you have this pristine vessel, then atheroma starts to accumulate this way. Okay, initially you see that this is the lumen. If you compare the lumen to the baseline lumen, there is no difference. That is because of positive remodeling of the artery, positive remodeling, and this positive remodeling compensates for the narrowing for some time. Sometimes the positive remodeling can go excessively as to lead to ectasia and aneurysmal formation in the artery. And that's why coronary ectasia, the most common cause of coronary ectasia and aneurysm, is still atherosclerosis. Okay, that is positive remodeling. And there is another fate, which is that positive remodeling starts initially, but as the burden of the plaque builds in and increases, it starts to narrow the lumen. So we have luminal narrowing that is gradual until it becomes severe enough to lead to symptoms. Or that plaque ruptures suddenly and a thrombus forms, and this is acute coronary syndrome. And this is chronic coronary syndrome. Okay. So We always look at the plaque in terms of this part and this part. This is fibrous cap and this is lipid core. Of course, there is inflammatory cells, macrophages, metalloproteinases, matrix, lots of other complex histology, but the most important two we look for in imaging is the fibrous cap and lipid core. Okay, the lesser the fibrous cap and the richer the lipid core, the more vulnerable the plaque is. So if you compare this one here, you see the fibrous cap, it is thick. The lipid core is just a small part. So this is a stable plaque. Compare this one with that much of lipid and this thin fibrous cap. This is more vulnerable, more susceptible to rupture and acute thrombus formation. Now the question is, 35-year-old gentleman developed anterior STEMI. 3 months ago, prior to his STEMI now, he has had CCT, cardiac CT, for atypical chest pain, which is reported as having 0 calcium score, a mild proximal LAD plaque. Which of the following is true? So this patient presented now with acute, with STEMI, and 3 months ago for atypical chest pain, he underwent cardiac CT, which was reported as 0 calcium score, a mild proximal LAD. So 0 calcium score, a mild LAD plaque is discordant. They cannot coexist, okay, or mutually exclusive. The plaque in cardiac CT likely shows high attenuation pixels. The plaque in cardiac CT likely shows positive remodeling. Large sheets of plaque calcification makes the plaque vulnerable. STEMI leads to only subendocardial injury. So which statement is true here? Okay, I'm waiting for your response.
Yes, Dr. Hatim, I think B.
B. Okay. So B. Any other opinion? Like if let's go one by one. If we say that the 0 calcium score rules out any plaque, is that true or false?
No, this is false.
Yes,
cannot
exactly.
rule out.
Yeah, it can't rule out because there are sometimes you have non-calcified atherosclerotic plaques. So though they might have high burden or they might be of high burden, but there is no calcium in them. Okay, so 0 calcium score does not rule out. Okay, now this plaque or the plaque is likely to show positive remodeling. Is positive remodeling a sign of vulnerable plaque or not? Because the question here points to that this patient 3 months ago was having mild, but most likely it was vulnerable plaque. That's why he presented 3 months later with STEMI. So what are the features of vulnerability of the plaque? Is positive remodeling one of them? Probably. Type is large sheet of plaque calcification one of them? We don't know yet. Type STEMI leads to only subendocardial injury. STEMI, as we said initially, leads to transmural injury and ST segment elevation. The one that leads to subendocardial injury is non-STEMI. Okay, so let's find out. The positive remodeling is defined as a ratio between a disease segment and a proximal non-disease segment more than 1.1. So there is a dilatation in the disease segment. So you have to see the disease segment like this one here. This is all atheroma on the wall. Compare it to this one. And this indicates that the plaque burden is really great. So it is one of the signs of vulnerable plaque. So positive remodeling is one sign. The other thing you remember, we said that lipid and fibrous tissue. The more lipid and the lesser the fibrous tissue, the more vulnerable the plaque is. Lipid, how do we know lipid? In CT, lipid has lower attenuation than muscle. So when the attenuation in the plaque is so low, the pixels or Hounsfield unit is less than 30 Hounsfield unit, that indicates more of fat, and that indicates more of vulnerability. Okay. Now, as to calcium, small speckles of calcification like this adds to the vulnerability of the plaque, but large sheets of calcium adds to the stability of the plaque. Okay. We also have, if I take you here, this is again low attenuation plaque, less than 30 Hounsfield unit. Spotty calcification is also a sign of vulnerable plaque. And napkin ring. Napkin ring means this is the lumen. You see the lumen is here. And around the lumen, you see atheroma. If you focus enough, you will see that this atheroma has two densities. You know, one darker, one less dark. This is fibrous tissue and fat. Napkin ring sign is a sign of vulnerable plaque. So the sign of vulnerability of the plaque in cardiac CT are positive remodeling, low attenuation less than 30 Hounsfield unit, spotty calcification, and napkin ring sign. And by spotty calcification, remember, because the question goes like this: when calcium is large sheets, it stabilizes the plaque. When it is spotty, it makes it vulnerable. So if we go back here, we said this is completely wrong, so we are fine with this. Now we go back to the plaque in cardiac CT shows high attenuation. You think that plaque has shown high attenuation or low attenuation?
Okay, low attenuation.
Low attenuation, exactly. So this is wrong. So it has shows positive remodeling. Yes, positive remodeling is a sign of vulnerability. Large sheets of calcium? No, spotty calcification, not large. And STEMI leads to only subendocardial injury, which is false up front. So the right answer is positive remodeling. Good. Now remember that the quality of chest pain goes from being central, pressure, squeezing, gripping, heavy, tight, exertional, retrosternal. The sharp, fleeting, shifting, positional are less likely to be ischemic in origin. Now, one of the things that you should remember is this one. That's why I derive it from the latest guidelines of chest pain evaluation. And here it is. Chest pain has been traditionally stratified into typical and atypical. Chest pain that is more likely associated with ischemia consists of substernal chest discomfort provoked by exertion or emotional stress and relieved by rest or nitrate. The more classic the chest pain discomfort is based on quality, location, radiation, and provoking a relieving factor, the more likely it is to be of cardiac ischemic origin. Atypical chest pain is a problematic term. Although it was intended to indicate angina without typical chest symptoms, it is more often used to state that the symptoms is non-cardiac in origin. So to diminish the ambiguity, use cardiac, possibly cardiac, and non-cardiac to describe the suspected cause of chest pain. So now, as to the recent guidelines, they no longer talk about typical and atypical and non-cardiac. It is cardiac, possibly cardiac, and non-cardiac. Okay, so they removed the atypical because atypical exported a message of that things are fine, it's non-cardiac. Okay, though it was meant to mean that this is ischemia with atypical presentation, but it was falsely reassuring. I remind you, the vast majority of chest pain we encounter day in and day out is actually atypical. So if you stick to atypical, you might rule out ischemia in patients who have ischemia. That's why it's better to have cardiac, possibly cardiac. Because when you say possibly cardiac, it means that, you know, you have to think twice before discharging this patient, or, you have probably to do further workup to make sure and stuff like that. So it's a stronger message to say possibly cardiac than atypical chest pain. Don't you agree? Yeah, and that's why it is cardiac, possibly cardiac, and non-cardiac. Now, women who present with chest pain are at risk for underdiagnosis, and potential cardiac cause should always be considered. So women most likely to present with atypical presentation than male counterparts that you have. That's why you have to be aware of the atypical nature of chest pain in females. In women presenting with chest pain, it is recommended to obtain a history that emphasizes accompanying symptoms that are more common in women with acute coronary syndrome. So women with acute coronary syndrome are more likely than males to come with atypical presentation. So no actual chest pain, but more of dyspnea, sweating, dizziness, stuff like that, you know. They are more likely to go atypical. Now, in patients with chest pain who are more than 75, acute coronary syndrome should be considered when accompanying symptoms such as shortness of breath, syncope, acute delirium are present, or when an unexplained fall has occurred. Okay, so now unexplained fall, delirium, acute confusional state, syncope, shortness of breath are all considered part of the presentation of acute coronary syndrome in elderly. Okay, and you have to consider that. Now, you might be confronted with a patient with chest pain either at OPD or emergency department, but the approach is more or less similar. So you try to categorize or stratify your patient into low risk, intermediate risk, high risk, or acute coronary syndrome. Acute coronary syndrome, no doubt, should go for coronary angio. Now, low risk, no testing usually is requested, okay, or required. The high risk, you may go for coronary angio or further testing, but intermediate risk, usually you choose to go for anatomical or functional testing, okay? So this is important kind of stratification based on preliminary data, which is usually historical data, presentational data, ECG data, okay? So according to this data, you put your patient into one of three: low risk, intermediate risk, or high risk. That's after ruling acute coronary syndrome. So if low risk, you don't need to do a lot, reassurance and secondary prevention, or addressing risk factors, stuff like that. High risk, you may go for coronary angio or further non-invasive testing, while intermediate intermediate risk patients go for non-invasive testing. I think this is important, and I can't overemphasize the importance of this. And I think you have gone through this so many times. So I'm hopeful that you know that so well. Okay. Now, low risk, no testing is necessary. Intermediate risk, you go for non-invasive testing. What is the non-invasive testing? Is it CT or stress testing? We are going to find out. But remind you here, factor that favors the use of cardiac CT versus stress imaging. Okay. It all depends on the availability and the expertise. This is the most important thing. So like in Khartoum, if we have nuclear and we don't have cardiac CT, or we have only one scanner across all Khartoum city, I think we should go for stress testing, whichever is available. If we have more experience in interpretation of stress echo, we go for it instead of going for something we have less experience in. So that is important. If the age is less than 65, that favors cardiac CT. More than 65, that favors stress testing. Okay? This is important. So the age might do something. Now, in patient with CABG or prior CABG, in patient with prior CABG presenting with acute chest pain, who do not have acute coronary syndrome. So you ruled out acute coronary syndrome. So performing stress imaging is effective to evaluate for myocardial ischemia or CCTA for graft stenosis or occlusion. بمعنى إذا جاك patient of CABG with chest pain, acute chest pain, and you ruled out acute coronary syndrome, it is class 1 to go for stress imaging. And by stress imaging, we mean stress echo, PET, SPECT, or CTA. So exercise ECG alone is out here. So don't recommend exercise ECG for a patient of CABG. You have to go for stress imaging. Okay? It's also in patient with prior CABG presenting with acute chest pain who don't have acute coronary syndrome or non-diagnostic stress test, invasive coronary angiogram is useful. What's the meaning of this? Because this is class 1 and this is class 1. They put it for your own judgment, okay? So it is upon the physician discretion which track to follow. Either a patient of CABG presenting with acute chest pain and you ruled out acute coronary syndrome, you can either go for stress testing, stress imaging, you can go for cardiac CT, or you can go for cath right away. It depends on your judgment. Okay? It depends on your judgment. So you might choose to take the patient to invasive coronary angiogram right away, or you may choose to send the patient for stress imaging, or you may choose to send the patient for cardiac CT. Okay? It's open for your choice. Good? Okay. Now, still the pretest probability depends on the chest pain and the age and male and female. So it depends on the chest pain. They also have dyspnea on the side. So this is the dark green, this dark green are the intermediate risk. You see, this is the intermediate risk. And we said that for intermediate risk, we need to do what? Non-invasive testing. For the light green is low risk. And by low risk, we mean less than 15% risk of coronary artery disease. In these patients, you probably don't have to go any further. Now, for high-risk patients like this here in orange, and high risk is defined as more than 50% risk of coronary artery disease. So if the probability or the pretest probability of coronary artery disease in a patient after evaluation is more than 50%, you might choose to go for invasive coronary angiogram, and that is right. You may choose to go for stress testing, imaging, and that is right. Both are right. It depends on you and how you evaluate the patient. Okay? But we all agree that the intermediate risk group, which is here, should go for non-invasive testing. Good. Now, let me read you this. Anatomic test, stress test. Because this has been a controversy over the last years, which to choose, because now we have 5 non-invasive testing. We have exercise ECG, SPECT, PET, stress echo, cardiac CT, and probably stress MR is in the pipeline. So we probably have 5 to 6 non-invasive testing. So for intermediate to high risk patient with a stable chest pain and no known coronary artery disease, CTA is effective for diagnosis, for risk stratification, and for guiding treatment decisions. So it's class 1, okay? Cardiac CT is class 1 for intermediate risk patient. Now, for intermediate high-risk patient with a stable chest pain and no known coronary artery disease, stress imaging, which is stress echo, PET SPECT, MPI, or CMR, is effective for the diagnosis. Is there any difference between these two? Any difference? There is no difference. Intermediate risk patient, no known coronary artery disease, CTA is effective, or stress imaging is effective. So which one to choose? That is left to your judgment. So they put no favorability of one over the other. But if you read between the lines, if they put CTA alone and the rest of stress testing on another side, that means they are implicitly giving a priority for cardiac CT. Or else they would have put cardiac CT here and we are done. But they put CTA alone. And that is based on what? That is based on a legion of clinical trials. Like PROMISE, it's called HEART and CONSERVE. In PROMISE, the 3 years coronary artery disease event rate for negative test finding was 0.9 for cardiac CT versus 2.1 for stress testing. What's the meaning of that? What's the meaning of that? The accuracy or the negative accuracy is more with cardiac CT than stress testing, right? The other thing is Scott Hart. The addition of cardiac CTA to standard care resulted in reduction in 5-year cardiac death and MI when compared with the standard care alone, predominantly exercise ECG. Now we are talking about cardiac CT might add a mortality value, okay, a hard outcome value compared to the other stress testing. In CONSERVE, the strategy of initial cardiac CT was associated with lower cost, but similar 1-year MACE rate as direct invasive coronary angiogram. So if you do cardiac CT before you send the patient to invasive coronary angiogram, that has reduced the risk, but not the adverse cardiac event. And we, of course, reducing the risk is a precious kind of a value we all seek. So these 3 trials, among others, has confirmed that cardiac CT has a priority. And the other thing is that cardiac CT more often prompts initiation and intensification of preventive and anti-ischemic therapies than other diagnostic strategies. Do you agree or disagree? Of course you agree because that's a statement. But how could you explain that? Why cardiac CT has led to more preventive measures than other non-invasive stress testing? Why?
Because can assess the plaque or atheroma vulnerability.
Good. يعني cardiac CT will give you data about the vulnerability of the plaque. Okay. طيب, what else? Stress data. مثلا النيوكلير it's reported as positive and negative, right? Right? It's reported as positive, negative. Then if it's positive, they are going to describe how positive. And if it's negative, it's negative. Okay? The stress echo is described as negative and positive. And if it's positive, I'm going to describe how much positive it is. So the stress testing are given in form of binary, positive, negative, positive, negative. And usually if it's positive, you will be inclined to go for CAT. If it's negative, you are reassured. But negative is broad spectrum. That negative result, it might be a patient with mild plaque, moderate plaque, or even severe plaque. But you don't see that by the nuclear, by stress echo. But by cardiac CT, you are going to see. So by cardiac CT, there is no negative and positive. Like stress testing, it's given as how much of calcium is scored. Is it mild, plaque, or moderate or severe? And if it's mild or moderate, vulnerable or non-vulnerable. So it gives additional data that maximize the data you need to use for preventive measures. Okay. But if a patient of nuclear study is negative, he might have calcium score that is more than 500, but I don't know about that. I will deal with him just like every other negative patient, reassurance and home. But the negative in cardiac CT might need to go for preventive measures because you have shown the anatomy. Even it's negative, of no clinical impact, okay? But they have a seroma and they need to start on preventive measures, okay? That's the difference between cardiac CT and nuclear. Now, this artery, as you see here, this is circ, left main, and you have the LAD. So what do you think is going on here? What is going on here? Yeah, anybody?
Yes, proximal LAB.
Yes.
There is stenosis more than 99%.
And most likely this stenosis is acute or chronic?
Most likely chronic.
Why did you say that? Okay, don't worry. What about this one here? This is circ and this is LAD, which is chopped off, and you see it here in another orientation. And this is also LAD and totally occluded LAD. These are all acute occlusions of Purkinje syndrome. Also here, these are acute occlusion in the RCA. You probably can also see a thrombus. See, this is a thrombus. You see the thrombus here? This haziness. This is a thrombus, okay? Compare this with this one. Now I need somebody to read this angio. So who can read this angio?
Yes,
REO.
REO view
Okay.
showing LAD is totally occluded.
Okay.
From the after the series diagonal.
Very nice. Good.
Normal LCX.
Normal LCX, right? And what else? That is, I will give you 2 out of 3. I will wait for you to have the full answer. 2 out of 3 is great
Yes.
because you are just getting 1/3.
No.
Look,
Yes, okay.
look at the frame without contrast. Without contrast.
Yes, there is dye hanging.
Is it dye hanging or calcium?
Okay.
This is calcification. You see, when the dye goes away, you see here at the proximal LED, yeah, this is calcification. This is heavy calcification in the LED. Okay.
Okay.
So
Okay.
this is usually how we score in the exam. So you put like 3 or 4 findings. غالبا الناس بتجيب 2 to 3 out of 4 and they miss a calcium here or stent there or some kind of collaterals, you know. But this is the stent and the calcium, you will see them after the contrast vanishes. So when the contrast goes away, you focus again on the fluoro and you will see the calcium and stent, okay? And also late filling. The late filling by collaterals, you will see it after some time when the dye goes away, okay? So this is calcification, and like you said, it's mid-segment total occlusion of the LED. Now, the right system is this. Who can take this? You see, again, this is the same patient, and you see here the calcification is here. You see, that's the calcification of the proximal LED. Okay, believe it or not, if it's put in the exam, they will give you 1 for the orientation, 2 for the lesion if it exists, 3 for the collaterals, and 4 for this calcium. Okay, so remember to report calcification in the arteries or somewhere else. It might be in the aortic valve, it might be mitral annular calcification, it might be precardial calcification. So you have to be open-eyed when you are interpreting the coronary angiogram. So now this is LAO, RCA, and as you see, just some luminal irregularities. No problem with the RCA, it's dominant. But what's the problem here? You see the collaterals going from the RCA, filling the LAD system. You see the LAD is coming late. That means because the LAD we have seen here is totally occluded chronically. This one here, okay. This is chronic total occlusion of the LAD, and this is RCA supplying collaterals to the left system. Septal to septal collaterals. Okay, good. Now, who can read this? Okay, you can take this. Nobody? Type.
Yes, again, this is LED, normal flow, but there is proximal calcification.
Okay, proximal calcification. And what about the LAD, which is here, the LAD?
There is bridging, myocardial bridging.
Not bridging. Look at it again. Look at it here. After the septal, the first septal perforator, that's the septal perforator. You see this one here? This is the septal. Look at the artery after the septal perforator. It is chopped off, totally occluded. What you see in here is a late filling by collaterals. That's why I told you, you wait for the contrast to go away and you look for calcium stents and late filling. That is always what we teach our fellows about. So when you have a contrast, the contrast is going to show you the stenosis. but you are going to miss calcium. You are probably going to miss stent and late filling by collaterals. So if you want to see the calcium, the collaterals, and the stents, look for dry fluoro without contrast. Okay. You see, after the contrast goes, you start to see the LAD because the blood flows comes to the LAD, or the blood flows to the LAD late with collaterals from the right system or right RCA. Okay. Now this is RCA. Okay. And it is subtotal. Okay. This is a chronic occlusion or acute occlusion? Is it chronic or acute?
The presence of the bridging collateral
Thank you so much. Thank you so much. Chronic. Exactly. Collaterals implies chronicity of the stenosis. And like you see here, these are jump collaterals from the proximal to distal. Okay, from proximal to distal, that's because the occlusion was chronic. Okay, chronic occlusion. Now, TIMI risk score is used for acute coronary syndrome prognostication. Which of the following is true about it? What is really amazing in the exams of fellows that they are loaded with knowledge. But when you go so simple, you know, they get confused. So when you ask them about TIMI risk score, and which are easy stuff, sometimes they get lost. But they can tell you a lot about more advanced stuff, because you know, the most simplicity is the ultimate sophistication. If you want to be a hard examiner, choose very easy physiological basic facts and points, and you are gonna fail everybody. So TIMI risk score is used for acute coronary syndrome prognostication. Which of the following is true about TIMI risk score? It uses point system to predict 30 days mortality in STEMI, non-STEMI, and unstable angina. Age and risk factors are common in TIMI score of STEMI and TIMI score of non-STEMI and stable angina. The simplicity of TIMI score does not affect the prognostic accuracy. TIMI score includes historical, history-related, presentational data, but no clinical exam data. So, which one is right? Which one you're gonna choose? Okay, is TIMI risk score about 30 days mortality? Yes and no. Okay, because what we have are two: TIMI risk score for MI and TIMI risk score for non-STEMI and stable angina, right? Okay, the TIMI score for MI defines 30 days mortality. The TIMI risk score for non-STEMI and unstable angina defines what? Defines what? 14 days mortality. 14 days mortality, not 30 days mortality. Now, if you see here, you have historical data, exam data, presentational data in TIMI score for MI. In TIMI score for non-STEMI and stable angina, we have only historical and presentation. We don't have clinical exam features. Okay, so both historical age is here. We also have age here. Risk factors are here. We also have risk factors here. Okay. Then in TIMI score for MI, we have systolic blood pressure less than 100 is given 3 points because hypotension with STEMI is serious. Heart rate more than 100 is given 2 points. CLIP class, which defines the level of congestion, is given 2 if it's 2, 3, and 4. If the patient is of low body weight, is given 1. Now anterior STEMI or left bundle is 1. Time to treatment more than 4 hours is given 1. Okay, and here are the risk mortality at 30 days. Now, when we go for non-STEMI and stable angina, we have age more than 65 is given 1. 3 risk factors given 1. Non-coronary artery disease stenosis more than 50 is given 1. Aspirin use in the last 7 days given 1. Recent severe angina 1. Elevated troponin 1. ST segment deviation 1. So they are 0 to 7, and it defines the 14 days mortality. Okay, so I'm going to take you back here. It uses point system to predict 30 days mortality in STEMI, non-STEMI, and unstable angina. Right or wrong?
Wrong.
Wrong. Because TIMI for STEMI is 30 days mortality. TIMI risk score for non-STEMI and stable angina, 14 days mortality. Okay. Age risk factors are common in TIMI score of STEMI and of non-STEMI and stable angina. Yes?
True.
Yes, exactly. Now, look at the last one, D. TIMI score includes historical presentational data, but no clinical exam data. That is for TIMI score of non-STEMI and stable angina. But for TIMI score of STEMI, there is historical, presentational, and clinical, which is exam here, systolic blood pressure, heart rate, level of congestion, and weight. Okay. Now, the simplicity of TIMI score has been criticized. It's affecting the accuracy. Okay. It is simple and easy going and stuff like that. But if you look here, for example, if a patient is taking aspirin in the last 7 days, is given 1 point. If there is elevated troponin, which is big deal, is also given 1. So they deal with all these risk factors like equally. Okay. So they try to make it simple, but simplicity has led to the, affect the accuracy, the prognostic accuracy. But it's still useful because the scoring system, this is the problem. This is the balance they have to strike. The scoring system has to be simple, but sometimes simplicity sacrifices accuracy. If you need to go complex, complex is not going to be useful practically, though it might be accurate in terms of diagnostication and prognostication. So it is striking a balance between simplicity and accuracy. Okay. Good. Now, stunned myocardium and hibernating myocardium. How do you define stunned myocardium? Stunned myocardium. What does that mean? Stunned myocardium. Anybody?
Stunt can be reversed.
Oh yes, good. This is good idea. Yeah. So stunt is reversal. Good. What else do you know about the stunning of myocardium?
Response للإنوتروب.
Okay. Also, you are right. You are on the right track. The response to inotropes is different. Yeah. But what's the meaning of stunned? Stunned means, do we have perfusion or we don't have perfusion?
Decrease the perfusion.
Decrease perfusion. Okay. Type. I want to show you here. Let's put perfusion here and function here. Function, by function, I mean contractile function. Okay. Okay. Let's take the probability of you have perfusion and you have function. This is normal physiology. If there is perfusion, there is function. Okay? Okay. Now, if I don't have perfusion, I don't have function.
Yes.
This is also commonsensical, because if you don't have perfusion, you don't have the blood supply for the muscle to contract. Okay? If I have perfusion and I don't have function, oh, this is a bit weird. This is stunning. This is stunning. Okay?
Yes.
Good. So this is
Yes.
okay. Yeah. So stunning means what? Stunning means the myocardium was, and of course, if I don't have perfusion here and I don't have function, this is ischemic. This is ischemia. No perfusion, no function. This is ischemia. Now, in ischemic myocardium, if you do revascularization and you restore the perfusion, so now you restore the perfusion, but the function remains low. This is stunning. Stunning. Stunning means الميوكارديوم حاصل له حالة بتاعت ذهول. ذهول. الذهول stunning translate in Arabic into ذهول. يعني رجع له الفيوجن لكن لم ترجع الكونتراكتيليتي بعد. فهو في حالة ذهول. حالة الذهول دي usually takes few weeks and the myocardium usually recovers completely. Okay? So when I ask you about stunning, I want you to tell me that stunning means the myocardium that was ischemic, they restore the blood supply, but it's still not contracted. Okay? Now, if I don't have perfusion, like here, and I don't have function, like here, no perfusion, no function. What's the meaning of this? There are three probabilities here. No perfusion and no function. It's either ischemic or hibernating or scarred. There are three probabilities. Either ischemic because no perfusion, no function, or hibernating, no perfusion, no function. Hibernating means it is ischemic and it is down regulating the metabolic activity to cope with the low supply of blood. Smart heart hypothesis. Or scarred, that no perfusion and now it is dead and fibrous tissue. Okay? And it is important to tell these three apart, because if it is ischemic or hibernating, revascularization is of value. But if it is scarred already, revascularization is useless. And here comes the testing for viability. Myocardial viability testing by different means to see if this heart is hibernating or scarred. Is it hibernating or scarred? Because they look alike in echo, but they don't look alike in the non-invasive testing for viability. Okay. Now look here. Don't look at this. Forget it. look here. This is PET scan, perfusion metabolism. We have a perfusion defect involving the apex and septum, right? That's a perfusion defect. We also have metabolic defect. What is the meaning of that? No perfusion, no metabolism. When you don't have perfusion and you elicit no metabolism in that part of the myocardium, that is non-viable tissue, scarred, because fibrous tissue is not metabolically active. But if you see here, we have the lateral wall is no perfusion. You see here? Now it is metabolically active. So though there is no perfusion, it is metabolically active. And that means we have viable tissue. Okay? So this is how PET scan decides about viability of the myocardium. If it is match defect, no perfusion, no metabolism, means scarring non-viable. If it is mismatch, meaning no perfusion, but metabolic activity is demonstrated, this is hibernating viable myocardium. Okay? Good. Now, vitamin echo. How we test for that? We give low dose and high dose of the vitamin. And we get 5 responses: normal, ischemic, viable, viable ischemic, and scar. In the normal myocardium, at baseline, this is the contractility. At low dose, this is the contractility. At high dose, this is the contractility. So there is incremental increase in the contractility as there is incremental increase in the vitamin dosing. This is normal. This is the normal one. Now look at the ischemic myocardium. Ischemic myocardium is hypokinetic. But when you give low dose, it becomes better. But at high dose, it goes low. Why is that? Because at high dose, you are gonna induce ischemia. At low dose, you are gonna induce recruitment. So at low dose, it improves. At high dose, it worsens. Now, look at viable myocardium. If it is hypo or akinetic at baseline, so no contractility at baseline, then you give low dose, it increased. High dose, it increased further. Okay. Now, for viable and ischemic, you give, it is akinetic at baseline, you give low dose, it's better. High dose, it goes low. Scar tissue is akinetic at baseline, remains akinetic at low dose, remains akinetic at high dose. Okay. The most important response is this one. I want you to know about this one. If you forget about all the rest, remember this one. We call it biphasic response. So if you give a patient, start with akinetic segment. You give low dose, it improves. High dose, it worsens. That means I have a viable tissue with ischemia. A revascularization is going to be beneficial. Okay. This biphasic response is the response we look for in the vitamin echo to demonstrate viability. So remember the biphasic response, what does it mean? Okay. Good. So are you following me?
Yes, we are following.
Good. Now, MRI. In MRI, we have ischemic pattern of hyperenhancement and non-ischemic patterns of hyperenhancement, gadolinium hyperenhancement. So if it is subendocardial or transmural, If it's transmural like this, involving more than 50% of the wall thickness, that means it is non-viable. But if it is subendocardial, small like this, but the remainder of the thickness is not hyper-enhanced, means viable, no fibrous tissue, it is viable. These are ischemic pattern. So the ischemic pattern by MRI are either subendocardial or transmural. The non-ischemic patterns are mid-wall, like this, or epicardial, like this, or global endocardial. These are all called non-ischemic patterns. It indicates non-ischemic cardiomyopathies like sarcoidosis, myocarditis, and Fabry's sarcoidosis, amyloidosis, and stuff like that. Don't bother about them, but remember the non-ischemic patterns are mid-wall, epicardial hyperenhancement, and global endocardial. The ischemic pattern is subendocardial and transmural. Okay, good. Now, troponin. How many troponin do we have? Anatomically, if you consider the structure of tropomyosin, myosin-actin complex, how many troponin do we have?
Three.
Yes, which are?
Troponin I, troponin T, troponin C.
Very good. So it is T, I,
Three
C.
type of troponin.
T, I. Okay. Which of these three we use for myocardial injury marker?
The most specific is troponin I.
I. And also we can use?
Troponin T.
Type. Can we use C?
C has isomerase in the muscle.
Very good. Very good. So C is non-cardio specific because it presents the same way in skeletal muscle. So it lacks cardio specificity. But T and I are cardio specific. Okay. And probably I is more cardio specific than T, but both are useful. T and I. That's why troponin T, troponin I, but never troponin C. Okay. Now, remember that after the myocardial infarction, it peaks at around 4 to 8 hours, 12, 18 hours, and then it goes down, and that might take days. This is important in the dynamics of troponin, okay? So if you have acute injury, troponin lingers on for days. And also there are two pools of troponin, cytosolic pool and myofibril pool. So there is a troponin in the cytoplasm, and there is troponin in the myofibril, okay? In the myofibril and the cytosol. So whenever you have cardiac injury that increases the permeability of the membrane, the cytosolic troponin leaks out. If the damage is severe enough to reach and attack and damage the myofibril, troponin is gonna leak out from the myofibril outside. Okay, good. Now, elevated troponin has cardiac and non-cardiac. The cardiac are acute coronary syndrome, myocarditis, heart failure, myopericarditis, cardiac contusion, tachyarrhythmia, if it is severe enough and long enough, cardioversion, CPR, post-cardiac surgery, and PCR. Non-cardiac. But non-cardiac etiology, you have to be cautious about the wording non-cardiac because it's cardiac. When we say that troponin is elevated with sepsis, It comes from the heart as well, but the cause is not ischemic myocardium. It is because of these factors are affecting the myocardium in different ways, leading to increased permeability and or damage of the myofibril system. Sepsis, trauma, CVA, chronic renal failure, pulmonary embolism, critical illness, rhabdomyolysis, extensive burn, cardiotoxic chemotherapy, scorpion and snake poisoning, severe hypertension or hypotension, carbon monoxide poisoning, ketoacidosis, COPD, severe anemia. Okay, these are all causes of elevated troponin. Okay. Now, the location of the myocardium function: anterior, septal, lateral, and inferior. Now, I need somebody to read this ECG for me. Who can read it?
ST elevation, ST elevation 2, 3 and ABF.
Okay.
2, 3 and ABF.
Very good.
ST depression lead 1.
Okay.
And ABL. ST depression 1 and ABL.
Okay. Good. And what else?
ST depression. ST depression in V2 and
Okay.
V3.
Very good. So, what's the diagnosis?
Inferior STEMI.
Yes.
With reciprocal change.
Yes.
And possibly RV infarct.
RV or posterior?
Posterior extension, yes.
Yes.
We can right side this.
Exactly. We do posterior leads. Good. Great. Okay. Now,
with complete heart block.
Thank you so much. Exactly.
Yes.
And complete heart. Well done. Well done. And here, again, we have ST elevation into 3 and ABF. Also, we have tall R, ST depression, and upright T, which are mirror image of ST elevation here. So probably we have posterior extension as well. And in this case, this is sinus. It is sinus. No blocks. Okay. Who can read this?
ST elevation.
Okay.
2, 3, ABF.
Very good.
V5 and V6.
Okay. And here also.
Yeah, V4, V5, and V6.
Okay. And also, we have also what here? In
ST
V1 and
depression.
V2. Yeah.
V1 and V2.
Yeah, sorry. We have here, okay? So this is also posterior extension. So we have inferior, posterior, and anterior, or what? What do we have here?
Lateral. Lateral.
Lateral. Exactly. What's the meaning of this?
The culprit region is different here. The LCX.
Can't it be RCA?
If it is RCA, we should see a reciprocal change in lead 1.
in lead 1. Honestly speaking, I might accept circumstances. It's very hard to rule which is which, or to tell which is which. What we have here is inferior, posterior, and lateral, which might belong
Yes.
to the step or even the arterial. Now the question is, could it be LAD that is large, wrapping around the apex, supplying the posterior wall? Could it be?
That
Yani,
it will present with anterior even, يعني anterior with inferior.
but here we have B2, 4, 5, and 6 are all ST elevation. They are anterior leads. So why not it's LAD with posterior and inferior? يعني إذا أنا عندي مثلا هذا هو ال LAD wrapping around the apex like that, supplying the posterior wall. And exactly. And I have block here. Okay. So I'm gonna have this one and this one, but no way to have it this way, because if the LAD is occluded, it's gonna affect the LAD area more than the posterior area, more than the inferior. So you tend to have more of ST segment elevation here than here. But now we have more of inferior ST segment elevation than lateral ST segment elevation. So the degree of ST segment elevation tells you about the origin of the artery. Okay. If it's LAD, you would expect more of ST segment elevation anteriorly than inferior. Okay. Good. Now, what is this? A patient comes with dyspnea on F, and you get this ECG. Are you going to activate the cath lab?
No.
Why?
وين طيب ايه؟
No, it's not. This is an old infarct.
Okay. It's an old infarction. How you be sure it's an old infarction and not subacute infarction like few hours today is?
The T-wave inversion.
The T-wave inversion. Okay.
It's a Q-wave and minimal ST.
The Q waves. But remind you, the Q waves start to appear few hours after the myocardial infarction. So I think this is the time when you have to look at the ECG, not as a piece of paper, but as a part of clinical context. Okay. So how the patient, previous history of revascularization, past history of STEMI and stuff like that. And you might need to do echo. Sometimes the way to solve this one out, is it acute kind of a problem or chronic, is to do echo. If it's chronic and this is aneurysmal scarred LAD, you are gonna see it in echo. If it's something recent, you are also gonna see it by echo. So yani, sometimes you can just settle the dispute about this kind of controversial ECGs by imaging, echo. Okay, but it is difficult to dismiss this ECG as, you know, this is chronic aneurysmal apex and stop here, because it might not be aneurysmal apex, might be subacute myocardial infarction hours or few days ago. Okay. Okay, what is this? How is this ECG?
wide-scale AC diffusion involving from V1 to V5.
Okay.
And also in some degree in V2.
Okay.
And resist elevation in AVR.
Okay.
And
So,
also there is a dominant R wave in V1.
okay. So now what you think about it?
Think about RBH.
Oh, great. These are typical features of RVH. This is prototypical ECG of RVH. Okay, so you have tall R in V1. Now why the markers are not pointers? You see here? And you have deep S in V6. You have right axis. You have so if you can mute, yeah. And this ST segment yeah, this T wave inversion is strain pattern. This is RVH with strain. Okay, RVH. Please can you okay, so this is RVH. Okay, so this is RVH with strain. Okay. Good. Now this is LVH with strain as well. Okay, LVH with strain. When you are quantifying chamber RVH, LVH, always have a good glance at the calibration here and make sure it is set right. So this standardization is 2 large squares. 10 millivolt equals 10 ml, 10 millimeter. Because if I put it at 3 large squares, I'm gonna have tall R's. If I put it at 1 square, I'm gonna have low voltage. So I can make artifactual low voltage and high voltage by changing the calibration. So make sure that the signal on the right, calibration signal, is set at 2 large squares. Of course, this is an ECG of pericarditis, and it is clear. Now we come to the T wave. Okay, we have symmetrical T wave, symmetrical tall, and asymmetrical tall. This one asymmetrical, tall is normal variant. Now, if it is symmetrical but narrow based and peaked like this, tends to be of hyperkalemia. Now, the broad based like this one here and not tented, it's a hyperacute of ischemia, which is the forerunner or the precursor of ST segment elevation. So if you see such kind of T wave, I advise you to stand beside the patient and do ECG after 10 minutes. Okay. Now, ST segment depression, it has different morphologies. We have the up-sloping morphology, the down-sloping morphology, and the horizontal morphology. Which one of the 3 is most specific of ischemia? Which one?
Horizontal and down sloping.
Exactly. But the horizontal is more followed, the down sloping is more specific, followed by the horizontal. And this is the least specific. But from down sloping and horizontal, down sloping is more specific than horizontal. Okay. Now, if you have this ECG, probably you have ST segment elevation on the anterior lead on both leads, on both ECGs. But if I ask you, could you quantify the amount of injury based on ECG? Could you?
Yeah.
How?
The magnitude of ST elevation.
Very good.
The magnitude of the first ECG, the magnitude of ST elevation given the thrombus tone pattern. That means we have a large infarct.
Very good. Very good. Yes. So, the magnitude and the extent. Look at here. How many leads are involved? V1, 2, 3, 4, 5, 6, and also 1 and AVL, right? So we have 8 leads here versus 6 leads here. This is one. The other thing is the magnitude. Also, the higher the ST segment, the more the injury. Okay? So the prognostication of ST segment elevation depends on the extent and the magnitude of ST elevation. And here, the ST segment elevation is quite big deal to the extent that it engulfs the entire ST and T wave. So instead of having R, then you have ST elevated, then T wave. This is all up. This part is all up here. So it becomes part of the R. Okay. So this is called, it has a name that is called tombstoning of the ECG, because it looks like the tombstone, يعني حجر القبر يعني الطريقة دي. Okay. Good. Now remind you that the ECG, the 12 lead ECG, especially the chest leads, are from V1 to V6. V1 is the closest to what? To the RV, right? It's the closest to the RV. But these leads actually pick up the electrical activity from the LV more than it picks it from the RV, because the RV is a bit outside this ECG camera. So in the ECG, in the 12 lead ECG, we are depicting different region, but ECG is missing the RV and is missing the posterior. So the ECG doesn't see the RV and doesn't see the posterior. That's why if you have a suspicion of RV infarction, you have to bring the leads here to the right side, put it here. If you are suspecting posterior, take these leads and put them in the back. Okay? Otherwise, the conventional ECGs is blinded to the RV and the posterior wall. Now, what is this? How can you read this ECG?
There is an ST elevation in lead 2, 3.
Okay.
Physical ST depression is 1 and ADL.
Very good.
And there is an ST elevation in V1 and V2 give a suspicion of RV infarct.
Thank you so much. Exactly. So here we have RV infarction. Usually, by the way, RV infarction does not imprint on V1 and V2, but sometimes it does. So if you see V1 and V2 ST segment elevation, suspect RV infarction, because V1 and V2 are the closest to the RV. So if there is RV infarction, it's going to appear here. But sometimes you can have RV infarction full blown and V1 and V2 are just perfectly normal. But if you have ST segment elevation here, that confirms the RV infarction. Okay, now this is the mirror image in V1 and V2. You are going to have ST segment depression and upright T. So when you look at it in the mirror, it looks like ST segment elevation and inverted T. Okay, who can read this? Who can read?
This is 12 light
Okay.
sinus risk. There is ST elevation in the inferior leads with
Very good.
reciprocal
Yes, you're right.
ABL. And then posterior extension, posterior and lateral extension.
Okay.
No conduction abnormality.
So you think in this patient, do you think in this patient that you have inferior or RCA infarction, circumfarction, and this is lateral, or you have LAD and this inferior extension of the LAD occlusion?
No, most likely it is due to circ occlusion.
Type. Okay, I told you before that the magnitude of the ST segment is gonna tell you about the origin of the occlusion. If you look here, the one I have showed you before, this one, the ST segment elevation in the inferior leads is more than in the lateral.
Yes.
Therefore, we are expecting to have RCA or circ with anterior or lateral extension. But now look here. We have ST segment elevation here more than here. So this is probably LAD infarction leading to inferior.
Wrap around.
Yes. How can we explain that? LAD and inferior, anterior and inferior, or anterolateral and inferior infarction the same time.
It could be due to LAD wrap around.
Yes, very good. So it's either this LAD that is wrapping around. So if it gets occluded, it's going to lead to anterior and inferior together. Or what else?
Or chronic occluded RCA with collateral from
Very
the
good.
LAD.
Very good. So if you have the RCA here, like this is the RCA. Okay, you see the RCA supplied by collateral, septal collateral from the LAD. So if the LAD gets occluded, we are going to lose the anterior wall and we are going to lose the collateral supplying the RCA. Therefore, we are going to lose the inferior wall as well. Okay, good. Now, if you look here, this is what's the problem here in this echo? What is this? What is this? This is small piece of meat here in the anterior leaflet.
Rupture papillary muscle.
Yes, this is rupture papillary muscle. This is also rupture papillary muscle. And you see the MR of rupture papillary muscle. And by 3D, you could demonstrate the cord and the papillary muscle quite clearly. Okay. Now, this complication is the one you see on the left, associated with soft murmur, occurs 3 to 4 weeks after the onset of MI. It doesn't occur with non-STEMI. Earlier surgery is associated with higher failure rate. Intra-aortic balloon pump is vital temporary hemodynamic support. So what is the complication here you see?
VSR.
VSR. Okay. It is not VSD. You see that the septum is what? Is aneurysmal, akinetic, and you have left-right flow through ventricular septal rupture. So Is it associated with soft murmur or loud murmur?
Most likely soft murmur, especially with a defect is small.
Okay. Any other opinion?
Loud murmur,
Huh?
because
The right answer is right and temporary.
Yes, yes. So the murmur of the VSR tends to be loud and sometimes associated with thrill. But the papillary muscle rupture MR is softish. Okay. Now, occurs 3 to 5 days after the onset of MI. Wrong or
Yes.
right? Eh?
Wrong early complication.
يعني
5 days.
as early as
Yes.
3 to 4 days. Huh?
Yes.
Yeah. It doesn't occur with non-STEMI. Does it or doesn't?
No, it can occur.
Does
Yes, it can
it
occur.
occur?
Exactly. Earlier surgery is associated with higher failure rate.
No,
No.
usually successful. Usually, the early surgery associated with good mortality.
Yeah, unfortunately, it's a dilemma, by the way. يعني VSR contribute a lot to hemodynamic collapse, cardiogenic shock, and all of that. So you have to intervene, and the earlier the better. But the failure rate is high. يعني the surgeon love so much to cool the patient down for this injury to solidify a little bit. So it's going to hold the patch. But they don't have this time, so they have to intervene early. But the success rate is so low, the failure rate is high, because this is necrotic tissue and you are gonna patch the necrotic tissue, so the patch is not gonna hold. So the failure rate is high, but you have to do it. There is no way out. Okay. Intra-aortic balloon pump, please, whenever you are faced with this kind of complication, put the patient on intra-aortic balloon pump. Okay. If that's a mechanical complication, papillary muscle rupture or VSR, intra-aortic balloon pump is of great help in improving hemodynamics. Okay. This is also VSR, and this is free wall rupture. Sometimes you need to use contrast to see the geometry of the wall and the contrast leaking out. Okay. It isn't easy, by the way, to diagnose free wall rupture, and contrast might be the way to go. Now, this complication is more common in the acute stage of STEMI than the late remodeling stage, most likely associated with visible, dense, spontaneous contrast. One of the indications for the use of NOAC, MR may decrease its incidence.
One of the indications for the use of NOAC.
Remind you, we are using NOAC for LV thrombus. And I was part of a study we published about the use of NOAC in LV thrombus, and we found that it is as efficacious as warfarin, but still the use of NOAC in LV thrombus is off-label. Okay, so it's not one of the indications. So which one is the right answer? Does it occurs acutely, subacutely, or chronically?
It occurs acutely.
exactly. يعني غالبية ال LV thrombus with MI بتحصل days to weeks after this. ما بتحصل month to years after. Okay. وغالبا الدنس spontaneous contrast might be seen, but غالب الأحيان you don't see. يعني في thrombus, but there is no dense spontaneous contrast. So the right answer here is MR may decrease its incidence. يعني if you have MR here, imagine you have MR. This MR is pushing a lot of volume here. كأنه is gonna be يعني sort of clearing the LV, improving the flow, preventing stasis, theoretically, right? And I was part of this study also, which in which we have seen the distribution of LV thrombus among patients with impaired systolic function across different spectrum of cardiomyopathies, ischemic and non-ischemic. We have found that, see here, from moderately severe to severe MR, which is R here, the distribution of LV thrombus tends to be low. So as if MR is protective a little bit. MR might be protective against LV thrombi. Theoretically, and from studies, MR might decrease the incidence of LV thrombus. Okay? But remember, this complication is most likely during the acute and subacute stage after STEMI, not the chronic stage. It can be found in the chronic stage. And in patient years to months after MI with aneurysmal epics, you might still find in the LV epic thrombus, but that's not common. It's more common to take place during the early days to weeks after the MI. Okay? Thank you so much.